So it is 6:43 p.m. I'm going to call the Board of Health meeting to order. For the members of the public who are waiting, thank you for your patience. I'm going to start with the roll call of board members. Dr. Osama Bilal.
Here.
Dr. Tyra Bryant Stevens.
Here.
Dr. Ana Diaz-Rue.
Here.
Dr. Marla Gold.
Here.
Dr. Jennifer Ibrahim.
Here.
Dr. Amit Ismail.
Here.
And Dr. Scott McNeil.
Here.
Great, thank you all. Has the board had a chance to review the meeting minutes from October 5th?
Yes.
And are there any questions? Is there a motion to approve the meeting minutes?
So moved.
And a second?
Second.
I have,
Um,
I have
yeah.
one correction. It says I was there and I wasn't.
Thank you. With that correction, do we have a motion to approve?
So moved.
And a second?
Second.
All in favor?
Aye.
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 Any opposed? Great, thank you. I'm going to turn to Ben now to explain the public comment process.
Thank you, Dr. Bedegal. Good evening, members of the public. This evening, we have an informational session, so there won't be any regulations to comment on, but if you'd like to submit a comment or question to the board members about any of the topics that we cover tonight, you can place them in the chat function, and I will forward them to the board or give the board time to review them. You can also email me directly at benjamin.hartung, which is in my display name at phila.gov. I will note that the board doesn't have to respond to your comment or question, but please feel free to submit them. And finally, a notice that this public meeting is being recorded per city ordinance and will be posted online on the Philadelphia Department of Public Health YouTube channel. So your participation in this meeting constitutes consent thereto to be posted on that channel. Thank you.
Thank you, Ben. So I wanted to update the board on the measles outbreak that we've been in the midst of. Just to give you an update, some of this will be background for those of you who are clinicians. It'll be too basic, but just so we have things like the number of days in the incubation period and so on in front of us. I'm going to try to share my screen, and I cannot. Ben, can you let me share my screen?
I will try, yes.
If not, I'll quickly email you my slides.
I just made you a co-host, so hopefully those permissions will be coming your way.
Thank you very much. All right. I can't, this is always the thing, I can't reach the slideshow. Here we go. Yeah. Sorry, everyone. All right. So just a quick overview. So we started out with an initial index case. It was a child from out of county who had traveled internationally, child under a year of age, hadn't yet been vaccinated. That child was admitted to Children's Hospital, in December with a respiratory bug and a fever. Wasn't obviously measles until the rash started. And so that child wasn't in respiratory isolation. There were 3 subsequent cases from that exposure inpatient at CHOP. 2 children, 1 parent. We have had 5 additional cases so far, and all of those additional cases were associated with an exposure at a daycare. So a total of 9 cases, 1 out of county, 8 in Philadelphia. There's also this 1 case in Camden that does not have a known connection to the Philadelphia outbreak. So as far as we know, that's not an associated case. So just, I know this is review for a lot of you, but we know that about 1 child out of 5 who gets measles will be hospitalized. It's actually been much higher in our outbreak. Majority have been hospitalized. 1 out of 1,000 will develop encephalitis. 1 to 3 per 1,000 will die, even with the best care. And the history in Philadelphia, we did have a big outbreak in 1990 with about 900 cases and 6 deaths. So in modern Philadelphia history, this has been terrible. The epi curve, that blue bar on the far left, is our initial case from out of county. You can see the orange bars are the cases who were exposed to CHOP. Then we have our in green, our initial daycare cases, and then in yellow, 1 additional case who was associated with that daycare exposure. We did not find out about the daycare exposure until about 2 weeks after it happened. So it was too late for giving post-exposure prophylaxis, either with vaccine or with immune globulin. And please stop me if you have any questions about this. So we have quite a number of exposures that resulted from this. One of the things that we've seen is that parents of children who have measles or adults with measles, before they develop the characteristic rash, they're quite sick. They go to a healthcare facility. The next day or a day later, they're not better, and they go to another healthcare facility. And so we've had a lot of healthcare facility exposures. We had a very helpful conversation with our colleagues in Columbus, Ohio, which had a large outbreak last year, about 85, 86 cases. And they saw similarly a lot of, we're getting a message that this will end in 10 minutes. Ben, any ideas?
Wow. I don't at the moment.
Okay. I'm going to go relatively quickly in case that's true. Anyway, lots of healthcare exposures, lots and lots and lots of work for the disease investigators, trying to track down who's immune, who isn't immune, and could still be vaccinated or given immune globulin if they need it. This is a quick overview of how we do post-exposure prophylaxis in case it's of interest. And, essentially for under 6 months, we can't vaccinate, even if they're within time. So we would use immune globulin. 6 to 11 months, we can give them our vaccine if we're within 72 hours. If it's within 6 days, we can use immune globulin. If we do that, we have to quarantine longer because you can have a protracted incubation period if you give immune globulin, and that's come up with a couple of our cases. Over 12 months, of course, giving vaccine if we have time, or immune globulin if there's a high-risk condition, for example, pregnancy for adults. So this is just a quick run through of what we've been doing. I will say our healthcare partners too have been working incredibly hard. This has been a full city effort, and I think it's almost all behind the scenes, so you don't see it, but huge amounts. And we have hundreds of people who were exposed and had to have their vaccine records tracked down. For people who didn't have vaccine records, our team has been doing home blood draws, especially for people for whom it was a hardship to stay home. So trying to establish whether they are truly immune or not. Having people quarantine if they were exposed and are not immune, if they're past the vaccination date. Lots of messaging on traditional media, social media, door-to-door outreach teams, giving information about measles vaccine, some extra measles vaccination clinics, robocalls, text messages. This is, it's really been a full city effort. So it's impressive, 8 Philadelphia cases in 1.
You can watch TV and this way it doesn't bother you.
John, you're not muted.
Sorry, everybody.
Okay. We've all been there. Anyway, lots and lots of work to try to contain this. Also messaging to healthcare providers. One of the things that we've been trying to make sure is that if somebody needs to send a patient who might have measles or has been exposed into a healthcare facility, that they call ahead so that that patient is quickly put into respiratory isolation, is masked on the way in. Having primary care providers, the hospital systems too, calling their patients in who are due for vaccination. We have figured that the highest yield would be the kids who are maybe just over 12 months, between 12 months and 6 years, who may not have gotten their second dose, for example, when it was due, or who might have been just old enough to get a first dose and haven't had a doctor's appointment yet. So really trying to get those kids caught up. Just a reminder, measles was declared eliminated in the year 2000. So we've had imported cases since then, but not sustained transmission. This is annual cases in the US. So in 2023, 56 cases nationally, handfuls in some years, one bad year in 2019 with over 1,000 cases. So Philly's 8 cases is noticeable on the national scale here. And this, I know you all know, this is more for members of the public listening in, but 95% of the population needs to be vaccinated to reach herd immunity. But of course, the closer we get to that, the more protected we are. Here in Philadelphia, 93% of our children 6 and over are up to date on their measles vaccine. In the school district, they're citing 97% of K-12 students who are vaccinated against measles, 94% in Pennsylvania, 93% nationally. So, Philly is a reasonably highly vaxxed place for measles, but there's still some pockets, some people who are unaffected. And where we are right now, our last case, that last daycare associated case, was January 13th. We can't declare this over until 2 full 21-day incubation periods after that January 13th case. So, we have a ways to go, but we're getting the last case, the last exposure that we were more worried about, a sort of a full-on higher risk exposure, was January 3rd. So we are starting to hope that we might get there, but we're not going to be done for a little while. So I'm going to stop on measles and just talk about the cremation regulation, but does anybody have any questions about the situation with measles right now?
Joe, can you just remind me of the Camden case and when that exposure or when that was known?
The date of
Just because
that.
of proximity to Philly and just.
Yeah, I'm not sure. I'm trying to remember, somewhere in the neighborhood of January 8th, but I'm not 100% sure. But there's been a lot of work done with reaching out to that family to try to see, and they haven't come up with any connections to any of the Philadelphia cases or places of known exposures. So it's thought to be an unrelated case, but it was not a case with travel. So we really don't know where that case came from.
Okay, thank you.
So the other item on our agenda for tonight is that, and I'm going to actually stop sharing my screen so I can see you all, I think.
Hey, Cheryl, I'm sorry,
Yeah.
Commissioner, just very quickly, sorry, I was,
Sure.
for immunization of measles, probably other childhood diseases, from the time of the pandemic, in terms of the percent that are not immunized, is the overall bucket of people who are not immunized for such a thing as measles going up due to the politics and associated issues over vaccine with COVID? Are we seeing anything like that?
So a little bit, but much less in Philadelphia than other places. We did have a dip in the pandemic, but we expected that because people weren't bringing their kids in for medical care. We've had some increase since then, but we're not back to baseline. And
Concern that parents or adults don't understand the severity of the disease, or walking
Right.
around saying, oh, it's just a rash, who cares, and putting it in that COVID bucket of disbelief. That's what I'm trying to get at, if we have a hand on.
I mean, I don't think at the kind of scale that you see in some places, but clearly, I think there are folks in Philadelphia who don't understand what measles really looks like because they haven't seen it. I think, and then it sounds like, when people think about it, well, rash and fever, okay, one of these things kids get, and not thinking about the neurologic complications, not thinking about the hospitalizations, even the deaths, and also just how sick kids are with measles. I think most adults now don't. I mean, my sister had the measles. I remember her lying in a dark room for a week, but I'm not sure how many adults have seen that up close. But Dr. Bryant-Stevens, you see kids in the office. Are you seeing more parents saying no to vaccines?
Certainly around the pandemic with all of kind of the miscommunications around vaccines, we were seeing some of that. But I agree with you, that's improved, that folks are understanding, kind of the importance of the vaccines. I was here in 90, working in Southwest Philly where the epidemic broke out, and it was awful. It was awful. And, we actually saw we had a kid who died in our practice, and it's just, those things are preventable, and it's just horrible to see.
Ben, did you want to say something?
Yes, sorry, I haven't been able to come up with a fix yet, but Dr. Bilal suggested maybe we can retry this link because we are going to get kicked out in a minute. Unfortunately, I apologize. I have to recheck my permissions on Zoom here. I was on a paternity leave, so but I just wanted to state for the record that before this meeting, the board met in executive session with its attorney to discuss litigation strategy in a specific Philadelphia Court of Common Pleas case relating to an order made concerning a request for documents made under the Pennsylvania right to know law. I have to say that for legal disclaimer purposes.
Thank you, Ben. So long as we're still here, I may get cut off, but I was gonna just talk through briefly. So back in June, we talked about and then voted to approve a regulation requiring permits for cremation, other types of non-burial disposition with a $50 fee. Since that time, Dr. D'Angelo, who was the chief medical examiner who presented at that meeting, has resigned. We have an acting chief, Dr. Lindsay, have Dr. Simon as our acting chief medical examiner. We talked through a number of things, obviously, when she started, one of which was that regulation. And she had some concerns that the cost could be a problem for low-income families and wanted to revisit that. We're in a situation where she's acting, we're figuring out what comes next. So what we've decided to do is to put that regulation on hold temporarily. So we're not asking the board to rescind it. We're not implementing yet. We'll figure that out going forward. So anyway, I just wanted to mention that to the board since that was something we had discussed here previously. Anything there we should talk about?
Just remind me, Cheryl, the cost was, what was the reason for the cost for the $50? Is it processing for the city? What's the
$50 essentially is that reviewing all of the cremations in the city would be extra work. So to bring in revenue to balance that.
Okay.
So, we may try to see if there's a way. And we also have some staffing issues right now in the medical examiner's office, but another option is to have the requirement, but without the fee. But I think we have to work through a couple of things first. Great. So those were all the items I have. Any other questions or comments before we close?
I have a question that's not related to any of this. And I think all the clinicians, Scott, I'm sure you've heard about this. One of the most popular controlling medications for asthma, they are no longer manufacturing, and it's created a really difficult time for families to get a substitution. Some of it's because of formulary, some of it's because of pharmacy, some of it's because of coverage, and it particularly impacts children because children need HFA, they need an inhaler, they can't do dry powder. And so just wondered if there's an opportunity for, I don't know, I've gotten calls from all over the city, so it's not just CHOP in terms of the concern around this, and I didn't know if it was anything that the city has done or thought about doing in relation to this, or ways to bring folks together to really address this.
This may be a little bit different from the problem I've been hearing about, which was the use of combined inhalers as both controller and smart therapy. So this sounds like you're talking about something else though.
No, this is totally different. Smart has so just briefly, smart inhalers are when inhalers have both inhaled corticosteroid and a long-acting beta agonist. So they have the rescue and the control of medicine in one inhaler. And on the asthma, the new guidelines, which are really not that new, 2020, but the new guidelines recommend SMART for a number of people who are on control of medications. That's been an issue in terms of insurance coverage for sure.
Yeah, and that one we've been working on, but this is something different. So what is the thing you can't get?
Flovent brand name.
Oh, yes, I do know about this. Let me. Yeah, so I mean, the short answer to your question is that, yes, one of the things we do involves talking with the state when problems are coming up like this. I mean, a wide variety of problems. But let me see where this one is, because I know we had a conversation about it the other day and I think had a solution, but let me, I'll
Well,
follow up.
yeah,
with
we
you.
have a solution, but the problem is there's a solution. The PDL was changed to include Asthmanex HFA for children. However, you just can't get in. We're also getting denials, even though it's on the PDL.
Okay. Let me see what I can find out. But I will follow up with you by email.
Okay.
Great, thank you. Anything else? All right.
We just received a question in the chat. If you would take a moment to review and see if you have a response.
Sure, I'll just read it out. Is there any concerns about the current COVID surge? Thinking about addressing it, any thoughts about reinstating a mask mandate in healthcare settings? So we did issue a recommendation for masking in healthcare settings. We aren't mandating at this time. The situation is not nearly at the level that it was in previous surges in terms of the hospitalization levels and so on. They've actually been coming down recently, which is good to see. But certainly, you know, we've been putting out information about the surge and would encourage anybody who has health concerns or just prefers to mask in crowded indoor settings. But that recommendation went out to healthcare institutions and providers, I think, in early January. Ben, I don't see any other public comments.
I just wanted to wait. Stan Juana, if I'm pronouncing that correctly, did you raise your hand for a follow-up?
Yes, just wanted to ask regarding the question or comment I left. I guess my concern comes from like someone who has long COVID and someone who is immunocompromised and goes to doctor's visit pretty often. So I guess I'm just wondering, because I've had instances where even asking medical professionals, it becomes almost like a safety concern, or something that is not always a safe conversation to have. Sometimes there is resistance from medical professionals, so wondering if there's any possibility a mask mandate can be reinstated for the protection of those who are disabled or immunocompromised, as we do participate in healthcare settings in a more often manner than maybe a more able-bodied person will be.
So, you know, in terms of just looking at the data and where we are at this point, we aren't, at least for myself, for the folks in the health department that I work with, we have not been looking to institute another mandate. I will say that if you are going to a healthcare facility and seeing a provider and you ask them to mask and they won't, you may want to consider a different healthcare provider. I mean, you know, sort of respect between people should be an important part of that relationship. But you know, I think we had mask mandates in Philadelphia for a long time, longer than most places. But I think at this point in evolution of COVID-19, I don't think that it's something workable for most healthcare institutions. I think individual healthcare institutions at this point, some of them have mandates for the worst part of the respiratory season, and I think that's something we'll probably continue to see in future years. This is a tough issue. You know, I think this board has struggled with it in terms of when to roll back the mandate and that balance of autonomy versus protection for vulnerable individuals. And I don't think there's any perfect answer there. Yes, Dr. Gold.
You know, just following up on it. So first of all, I don't support the mandate. I do any mask mandate at this time by us as policy. I do understand, of course, and I think we all do, the issue that's been brought up here. And I would just say, you know, and I always use my mother as a personal note in these meetings because I take her to all her appointments. She's now 91 and otherwise doing well. The data on one-way masking, because I'm even surprised that what we are seeing again are what lovingly called baggy blues. You know, people are just wearing, even if they wear masks, I'm not even sure if it's better than nothing. They're not very useful. And because we have knowledge and we have resources, you know, I make sure that my mother's is always in a KN95 and can breathe comfortably through it while we're waiting for appointments. And I'm not concerned about asking a provider to wear it. All this to say, Commissioner, that while I don't see a need for a special communication now, I think the health department reminding providers that if they're asked to, you know, some kind of language, and perhaps you can tell us that it's been done in the past. Just last week, I had a situation in an eye doctor, you know, where the person was going to be nose to nose with someone, my mother, who's immunocompromised, and I had to ask them to put on a mask. And when they said, well, there were none in the room, I said, I'll wait, go get it.
Yes. So yeah, we sent something to all providers a few weeks ago, asking them to mask. And, you know, I think at the point at which we roll that back, and again, it's not a mandate, it's a recommendation, but at the point at which we roll that back, I think it would be very appropriate to include a reminder that even when there's no recommendation for everyone to do it, if the patient wants it, it's important.
Yeah, and just a quick follow-up on that. You know, one of the, for better or worse, one of the reasons that we're seeing this is it's possible we're seeing people not mask in the workplace, such as, you know, healthcare providers, because they just got there within a window. They had COVID, they're negative now, they were very responsible and they're happy to be out of a mask, but there's no way to know that. There's more nuance than I care to think about at this point with immunity in this disease. But just the same, I don't know that I support if your doctor doesn't do it, get another doctor. That's not so easy. I think strong reminders and available masks that are appropriate masks. We're going to be in this for quite some time.
Looks like we have one other comment from a member of the public.
Thank you so much. Yes, my name is CJ. I wanted to share, thank you so much for sharing. And I wanted to add that a comment regarding masking in a healthcare setting, especially when immunocompromised or disabled patients do ask. I'm curious if you have data on when there are instances when patients ask that they may risk being documented as difficult patients. And the suggestion, I just want to share that the suggestion of, in addition to that risk, it weighs heavily on patients, especially of those of whom who are disabled and immunocompromised, and that risk follows them, right, for every subsequent appointment. But I also really think it's critical to be mindful of a response, including just changing providers, and that will solve your problem. That is not feasible for many patients, especially when it comes to insurance. But it's especially critical for many disabled and immunocompromised patients that they continue in the same practice. And those barriers are very real. And that kind of response is lacking not only in nuance, but you're missing entirely an operating bias and the very real reality that many people face, especially disabled patients. So I appreciate your sharing, but I think that there is a lot of, a former position, I was a clinical research coordinator at Penn. and while not working in the clinical side, collaborating with who then enrolled as subjects in COVID research that I was conducting for 2 years, that I am very aware that this kind of documentation is real, but I can only imagine what those on the clinical side see. But I absolutely am aware of disabled and immunocompromised peers of mine who experience this. So I hope that that is factored into any response moving forward, and certainly something that I hope that more robust data and even in the absence of data, it's critical that that's taken into account. Thank you so much.
Thank you for sharing that. So, I think as we're shaping the suggestions or the recommendations for healthcare providers, as that recommendation for uniform masking goes away, I think including something about asking every patient to avoid stigma, it seems like a really helpful suggestion. So thank you. So
One thing I wanted to mention regarding this, that recently for something else we were reviewing the evidence of filtration, and I'm wondering if that I'm sure that healthcare providers are aware of this, but maybe this is a recommendation that the health department could put out on the efficacy of filtration in clinical settings to address at least when one-way masking is present and healthcare providers may not want to do this filtration, at least can help reduce the risk of infection. There's a recent meta-analysis showing that I can share if needed. Because that can be helpful, and especially for smaller practices that may not have the resources to review all of these things, it may be useful if the health department puts a recommendation regarding that.
I support that. In many cases, those machines are there, Dr. Bilal, and they're off, they're turned off. So I think, and just for the folks from the public that are here, please know, and the board knows, at least I can relate to, that there's a significant number of people for who life has been completely turned upside down for the foreseeable future by this disease. And any way that we can help shape the communication in healthcare settings, in clinicians' offices, with certain reminders or materials, however we can support that with the resources available, that we should.
Yeah, I think this discussion has been really helpful as we think about our communication. So thank you. So with that, it is 7:18 p.m. I'm going to declare this meeting adjourned. I really want to thank you all for your comments and for your time. Have a wonderful evening.
Thank you.
Take care, everyone.
Thanks. Have a
Thank
nice
you.
evening.
Bye.